All
All right,
right.
everybody. We are we are live.
Cool.
Welcome, Dr. Amaral, to another episode of our PALCUS live webinars. We're here to get an update on COVID-19, and welcome to Denise, my esteemed co-host, who we are becoming quite the Zoom live webinar podcasting. We're going to start our own media company, Denise. How about that?
Yeah,
I was thinking that.
I'll wait to see if the Trump company is
Right.
is
We'll go
successful
buy it.
I was
and then
thinking
we'll go
that's.
buy it. Yeah,
I think that would be a great business opportunity for all of you. We need to turn all the
Right?
negatives of COVID into the positives, right? So
it's
Positive,
true.
right? New business
that's
opportunity for sure.
That's true.
exactly.
Well, I mean, unless you're living under a rock, everybody, COVID has spiked again, and we are. We have another.
So that's my friend, Dr. Inicelli. I sent him my invite. So he's listed as a participant right
Okay,
now. And perhaps
okay,
we can block out his camera. Can you do that?
yeah, I will. I'm gonna demote him.
Oh,
uh,
it's okay. I'm glad he joined.
there we
Great.
go. There we go.
Good.
um,
So,
So we're here to get an update on kind of everything that's going on, vaccines. I know you have some slides that you want to share, Dr. Emerald, but thank you for joining us again. And we can have just discussion on what's going on, because for those of you who don't know, my husband and I have COVID. And I actually called Dr. Emerald about a week ago and I said, this is what happened. Am I going to get it? and here we are.
so great. I'm going to share my
Yeah.
screen, and
Yeah, go ahead.
so please let me know. I'm assuming that right now you can see it.
Mm-hmm.
Yes, we can.
Great. And so I'm going to run through this. And I think, as you said, second wave, third wave. I'm really thought, well, what could I really give information to folks that would help them during the holiday season, and perhaps put a lot of this into context, since there's so much information available. So my roadmap of topics I want to touch on are, where are we today? What is quarantine, isolation? What should we do? If we're positive, what are our steps? Angela, this is specifically for you, I guess, now that you've told me the news. A little bit about testing and vaccines. Testing is a lot of confusion, and I can help perhaps put that in better context. Vaccines, we know that we're going to probably have announced no later, probably within 2 days, approval of the Pfizer mRNA vaccine. So I want to touch a little bit on that. When is this going to end? And then finally, what should we do for Christmas? So, since we're all Portuguese in one way or another, I wanted to start with Portugal. There's been a significant rise in cases in Europe over the last 2 months. It started to rise at the end of August, and really started to slope upwards in September and hit its highest peak in October. So in Portugal, you see they're actually starting to come down. In fact, pretty much all countries in Europe are coming down, except Germany's having some trouble. So Germany has reached their peak, but it's flat. But here you see this coming down. They instituted partial restrictions. You have to wear masks. They close things at certain hours, and they're doing quite well. But, one of the problems of COVID is that it carries with it a toll of loss of life. And you see that simply by this increase in numbers of cases from down in the 2,000 or 1,500 range. It was 20, 30 people per day dying, and now you're up in close to 100. And that will lag the cases. So in the United States, we have a very different picture. And what I can always see is these three sort of peaks. So we have this first peak when it was really introduced, driven mostly by New York. Then we have a peak that occurred in the summer, probably in large measure by the congregation of events that came from Memorial Day weekend, 4th of July weekend, summer, more interaction, opening things up. And now we've had this latest peak, not completely understandable why. could be somewhat related to school openings and universities, can be related to changes in temperature and being indoor more. But we really have no end in sight to this at the moment. So we're on the upswing. And as you see also, it parallels with deaths. And so, the loss of life from this is pretty substantial and is really the reason why COVID-19 is a problem. If it was just about getting an infection, it would be okay. But people do die, and there is long COVID, which I will not talk about today. But things aren't necessarily as they appear. And I really wanted to emphasize this for folks, because we tend to always think about this as a disease that affects the elderly. And in fact, if you look, the greatest percentage of people who have died from COVID so far are those who are over 65 years of age. 75% of people actually fall in that age category. But what's interesting is, to me, is looking at it a different way and saying, what's the actual impact on society? When an individual dies, it's terrible for us and those who know that person. That's a life that's lost. But what's the bigger impact on society? And if you calculate the number of deaths that occur less than the 25% less than 65 and the 75, and look at it in terms of how much aggregate life has been lost, what you find is that those 25% who've died have accounted for 1.3 million years of life lost, compared to 1.6 in those over 65. So we've lost a lot of talent, a lot of it's just a big loss to society. So we shouldn't be thinking this is just a disease of the elderly, because the problem is we don't know how to predict who these people are. And so, yes, comorbid conditions are important, but that's not the case. But on the other hand, there's good news, because, and I personally believe, I'm not, I wouldn't go on my, I can't data drive this, but we do know that the length of hospital stay is dramatically decreased for patients who end up in the hospital. So even those who get COVID and end up in the hospital have a much brighter prognosis. It's over half reduced, and many less patients are requiring ventilation or going to the ICU, another great thing. And a lot of this has to do, I believe, more with the care they receive than with medications and drugs, although they clearly have a role. So good news is, even though more people are getting it and there are more people dying because of it, the overall number of deaths is decreasing proportionate to the number of people that are getting it. So where do you get this? The highest risk areas are pretty well documented at this point. And I think the number one area are restaurants, according to most sources, and data, and bars. And it's kind of simple. You're in a closed environment and you don't have a mask on. So, and there are people that are in there all day. It's not just like you go in or out. So restaurants and bars are places that really should be avoided at all costs. Even outdoor dining is not completely safe. You still don't have a mask on. You still have people in close contact. And I do believe in California that in many of the counties that's been closed as well. Houses of worship are another problem. And, certainly a bigger problem even entering into Christmas. But many of the large super spreader events have come from houses of worship. These are places where people are for 30 to 45 minutes. There's singing, there's a lot of stuff going on. And frankly, they're not designed to have, the best ventilation system in them. Public transportation, buses and trains are also identified as an important source of spread. Airplanes themselves probably have a low risk of spread, but airports are more of a problem. And finally, gyms is another place that has been identified. Now, one of the things that's difficult for people to contemplate is that when these data are created and these things are determined, they're being identified at a time when there was maybe 40,000 cases a day in the United States. When there's 200,000 cases a day, these risks are all dramatically changed, and they also start to impact other areas more importantly. So today, one of the most common places for people to get COVID-19 is in their home. The reason is you're not wearing masks in your house. And if both people are not stringently following rules, or your spouse happens to be a healthcare worker, as happened to one of my friends, and they get it, then you get it. So it's becoming increasingly more difficult to control as cases get higher. That doesn't mean we shouldn't continue to try, though. So what happens if you are in close contact with someone with COVID? And what does that mean? The CDC defines close contact as being near someone 6 feet or less for a total of 15 minutes, not continuous 15 minutes. That was the original thing. So if Angela and I are interacting close to each other, 2 or 3 feet apart for a couple of minutes, and then we separate, and then we come back, and then we separate, and then we come back, as might occur in a party, that 15 minutes is the amount of time that's necessary. And typically, we don't know that the person has COVID that we're talking to. They look fine. And as I'll explain in a minute, that's because you're most contagious prior to symptoms. So if that happens, what should you do? Well, the answer is quarantine. And that has a huge burden placed on people. Can't go to work. There's a lot of issues here. It's not a simple measure. And the standard rule has been quarantine for 14 days. And that was done by evaluating patients early in the pandemic, where it was identified that over 95% of people who develop symptoms within 14 days. Therefore, if you go 14 days, you're probably fine. And that's been the rule. And in an attempt to try to ease the burden of quarantine, which would hopefully mean that more people will quarantine, there's two options that the CDC recently released. One is 10 days. After 10 days, if you don't have symptoms, the chances that you will be positive, that you will develop symptoms afterwards, is about 1%. The second option is 7 days and then a test. So if you go 7 days without symptoms and then you get a test and it's negative, you can break quarantine. That's got a 5% chance. So the CDC still says that the 14 days is the best, but 7 days with the test is fine if you follow that rule. Angela?
So I have a question about the 7-day quarantine. So that would be if you were exposed but hadn't gotten a positive test result, correct?
Correct.
Because
correct. That's isolation. So
right.
You are in isolation, and I'll come to that in a minute.
Right. But
so just these are people, right, to emphasize your point. Sorry, go ahead. You were going to say something.
I was just going to say, because our primary doctor told us that, because we asked, should we go get a negative test after a certain amount of time? And they said, well, you can test positive for months after, because it stays in your system, even if you no longer have symptoms. And so I just wanted to kind of clarify.
So, and that's on the isolation piece. And that's a really important point that I'm going to bring up. As it is now, this is when you've been, so I happen to be near you, and now you've called me and said, whoa, hey, Dr. Joe, got some bad news. I tested positive, and we were hanging around together. Okay, so I now have to quarantine. I'm going to quarantine for 14. I'm not going to get a test. Don't get a test, because the test is probably going to be negative. And I'll talk about that in a little bit in a minute. But in general, all you do is quarantine. And, if you get a cold, you still quarantine, but assume you have COVID. Don't assume you have a cold. So you would then be symptomatic, and you'll go into the isolation group. So there's two groups, quarantine, isolation. Terms become confusing. Here, 14 days is the standard. So if you work from home and you don't have to go out, do the 14 days. If you have to go out, there's 7 days and a negative test. And we'll talk about tests later. If you test positive, now you are isolating. So Angela, you're in isolation, and you have mild to moderate symptoms. So for people who have mild to moderate symptoms, you need to isolate for 10 days. After 10 days, you do not need a test. You're done. You're done isolating. At 10 days, you will no longer be shedding virus that can replicate. You will shed virus. I'm going to show you the data. Active virus is not shed after 10 days. So it's 10 days from symptoms. One of the problems that you'll come across is your doctor, this doctor, everybody says different things, gets completely confusing. So simple rule, the day of symptoms, 10 days later, you are free. You will not shed. You do not need a test.
That's good to know.
Yeah. And now that's if you're free and you don't have symptoms. If you have symptoms, you probably should still stay home, but you're still not going to shed. I don't want to confuse you, but just a good idea because you can get worse over time, right? The problem here is you can get over the initial infection and get pneumonia or some other thing. So, you need to be careful. Now, if you have severe COVID and you end up in the hospital, that group of people can shed longer, up to 20 days. It's usually around 15. So you would go longer for those people in isolation. But 80% of people who get COVID are not going to get severe COVID. It's about 20% that end up in the hospital. So, the majority are going to be in the upper group. So quarantine, 14 days or 7 days plus a test. Isolation for those who are positive. And here, 10 days is the rule. So when are you infectious? So here you see that typically the period where you're most infectious is about 36 to 48 hours, 24 to 48 hours before you develop symptoms. So Angela, if you develop symptoms on Sunday, your highest risk to spread the disease was on Friday and Saturday. And that's why this is such a difficult problem to stop. The typical period where people will develop symptoms is somewhere between 5 and 7 days after exposure. It can be as early as 2 days, but on average, it would be 5 to 7 days. So you can do these calculations as we did before the webinar to kind of figure out where your most likely exposure point was. After 10 days, you may shed virus, but it's not active virus. Remember, as you'll see in a minute, these tests are not measuring. When you do a test for a bacteria, you culture the bacteria and you look at the bacteria grow. In the tests we do here, we're just looking for genetic material or for proteins. So there's stuff that's coming out. There will be virus in your sinuses, mucus, for example, that has been destroyed by the T cells in there, but it's got to get cleared. So you'll continue to put it out. And that's why there's many reports of people shedding the virus in stool or in mucus or cough, but those are not culturable. They won't infect cells. 10 days is the rule. Now, for the tests, which becomes the next point of confusion for everybody, I don't want to go into a lot of detail on the virus, other than to say the virus has these things sticking out of it, and they're different forms of proteins, which the body recognizes as foreign. They're antigens. So the body is going to see that protein out there and say, whoa, this doesn't belong here. I'm going to kill it. And in the case of COVID, we can either measure the presence of the proteins, which are antigen tests, or we can measure the presence of the RNA, specific sequences of RNA that correlate to that of the virus. Those are the PCR tests. So there are two basic classifications of tests: diagnostic tests, which tell you you have an infection, and one is the PCR test, which measure nucleic acids, RNA, pieces of RNA, and then the antigen tests, which measure protein. We have another completely different group of tests, which are called serology tests. They measure antibodies. They don't tell you you have an infection. They tell you you likely were infected 15 days or more prior to the test. So one of the things that you might want to do, Angela, is in about 2 or 3 weeks, get an antigen test. See if you've mounted an antibody response. You'll also ask me, well, should I get a vaccine? The chances are probably yes, although I'm going to hedge on that till I find more information in the data. So the best test to get is a diagnostic PCR test. That's this group here, which apparently I forgot to put on there. So the PCR test is done with a nasal or oral swab. There's a little bit of evidence that when you do it nasally, you get better results than orally, but it's not that clear. The problem with these PCR tests is they take longer to do. The average time to do a PCR test is 4 to 5 hours. There are some machines that can do them in an hour if they happen to be right next to you. So it can take a day or two for you to get the result. They're much more sensitive and specific. You don't need any other test. And if it's positive, we need to assume that you have the infection. If it's negative, it doesn't mean you don't have it. But there's a higher probability that you don't have it than with the other type of test, which is the rapid antigen test, which is this middle box. Here, again, it's done by a nasal oral swab. This one takes hours or minutes. I mean, you can do this pretty quickly. And if it's positive, you don't need another test. But if it's negative and you have symptoms, if it's positive, you should confirm it with a PCR. If it's negative, and you have symptoms, you should get a PCR because their accuracy is lower. They are most accurate when you have symptoms, but in the absence of symptoms, so that's why if you have symptoms and it's negative, it could be a false negative, therefore you get a PCR. And so this is a probable, this is a definite, this is a probable. And as I said, this is for immunity, but it doesn't tell you anything else. None of these tests are FDA approved. They're all approved through an emergency use authorization. And there are dozens and dozens of tests. They all have different sensitivities and specificities. And frighteningly, as infections increase in number, those sensitivities and specificities also change. It's for another webinar. So again, remember, the PCR test measures nucleic acids. It's measuring pieces of RNA. It's not telling you there's a live virus there. Antigens are measuring the specific proteins associated with the virus. So when should you get tested? You should not get tested if you've been in contact with someone, because the test is probably going to be negative. If you do want to get a test, you should wait 5 to 7 days. So you should quarantine and then do your 7-day. You should do your 7-day quarantine and get the test, which is what the new CDC recommendation is. However, you should get a test if you have fever, chills, cough, shortness of breath. I mean, the typical things. And I would say that now that I talk to about 3 or 4 people every week who've developed COVID, the most classic symptom is these aches and bone pain and fatigue, and usually associated with a low-grade fever. And so any of these things are possible. Sneezing, interestingly, is not one of the typical symptoms. So, allergies tend to be more of the sneezing. But here, you would go get a test. Now, why do you want to go get the test? Because you're going to isolate or quarantine. It's a little bit different what you do isolating and quarantining. I mean, isolation means you lock yourself in a room by yourself and somebody brings you food with a mask. Quarantining means you stay in the house, but you're not outside. You probably should wear a mask in contact with others, but that's kind of, it's different. So the reason you should get a test, and this is particularly important for people who are 65 years of age and older, is that it's important to know that you have COVID. Because monoclonal antibody therapies, which I'm not going to go into detail today, work remarkably well if given within 10 days or so of the onset of symptoms. Now, the way that was done is that they gave it to people who were outside of the hospital, and they saw a dramatic reduction in hospitalization and severity of disease. They gave it to people in the hospital and they saw no change. The way it's been broken up is 10 days, because most people who get COVID will get severe COVID within 10 days. There's only about 100,000 doses of this available in the United States. So it's an extremely short supply. So it's rationed to people who need it the most. And the main target group are those who are most likely to get sick and die at the moment, those over age 65. So knowing you have this will expedite that process. You don't need to get it though if you just, get mild COVID. I know 4 people over age 75 who've gotten COVID and they've done fine and they haven't gotten any symptoms and they didn't need monoclonal antibody. So that's one of the main reasons. And then the other is, so then you can follow up with monoclonal antibodies and know what your status is. So this is what you were talking about earlier, Angela. So the SARS, the RNA sort of you're going to get RNA and it's been measured all the way out to 83 days in people, but by 10 days, you're no longer shedding active virus, infectious virus.
Okay.
Now, what do you do if you're positive? So one of the interesting things about COVID is, like any pandemic or novel disease, everybody comes up with every possible treatment that is, in the earth, in the globe, and start throwing everything at it. And having randomized control trials, having good, big data analysis usually is a pretty good idea. So there's a lot of things that have become sort of home remedies. There's some suggestive evidence, but not really very good. So this on the left is from the Eastern Michigan School of Medicine. And they have protocols, which for prophylaxis, they recommend vitamin C, D, B, zinc, melatonin, and ivermectin. Ivermectin is a drug used for lice, for parasites. I look at that and I say, wow, who studied the interaction between all those medications? Nobody. And there is no good evidence that any of these work. In fact, vitamin C was done in a randomized controlled trial where people were given high doses of vitamin C and it didn't work. Now, vitamin D is also another one. And the bottom line is vitamin D low levels of vitamin D have been associated with severe COVID pretty consistently. On the other hand, giving people vitamin D has not shown any benefit. Nevertheless, giving people vitamin D is a good idea because, especially in older people, their vitamin D concentrations are low. They tend to be inside more. So that one kind of makes sense. And then the zinc, that simply came out of hydrochloroquine, zinc, and azathioprine. And that's become a whole other, ball of wax. So you can do whatever you want as an individual. Those are your choices. And then for mildly symptomatic patients, they really don't change anything other than they add aspirin. Now, the reason for the aspirin is important because there's a few studies that have shown that patients who have heart disease that were on aspirin prior to coming into the hospital survive more than those who weren't. And, this is all an inflammatory immune disease, and aspirin and these drugs all interact. If you want to take a non-steroidal like Advil or Motrin or whatever you take, that's fine. There's no negative impact of that, although earlier there was thought to be. You want to take Tylenol, that's fine. So what do I tell people? I tell people for prophylaxis, basically stay home. And when you go out, wear a mask. Don't be in a crowd. Don't be any place for 15 minutes. The best prophylaxis is to avoid exposure. All this other stuff, not relevant to me. If you have mild COVID or mild to moderate COVID, moderate, and your age is young or even if it's not, I just tell people take a multivitamin because in a multivitamin, you're going to get vitamin D, you're going to get vitamin C, you're going to get everything. And those are tried and true. They don't cause any problems. We know what they do, and you don't need super physiologic doses. There's no evidence that works. I recommend that people do take vitamin D, but rather than the 20,000 units people say, I think 400 to 800 international units is fine. You can go as high as 12. And that's as much just simply good health measure as not. If you didn't have COVID, you should probably take vitamin D. I do think people should take a daily aspirin if they're not on any anticoagulants or already taking blood thinners of some sort. You should definitely have a pulse ox in your house and take your pulse ox, your oxygen saturation. Order one from Amazon. They're only $20 or $30. It's a good thing to have at home. That'll be one of the new things that comes out of the pandemic. You'll have a thermometer and a pulse ox. And perhaps most importantly is don't try to minimize the disease. I constantly hear people that have it saying, it's not that bad. Yeah, but I look at them and it is bad. I mean, it's not normal. Whether you have the flu or whether you have COVID, rest, fluids, those are, and that was actually true with the great influenza of 1918. That's a really effective measure. Now, if you're over 65 and you start to get worsening symptoms, you are a candidate for monoclonal antibodies. So when you get symptoms, the first thing to do is call your doctor and get their advice. But if you call me like Angela did, I think this is what I told Angela. And so this is my sort of standard regimen of what to do. So we've talked already about this. Most people are asymptomatic or pre-symptomatic. And so the positive tests are occurring in people who don't have symptoms when they're done early, but they will. So a lot of people in 14 days, if you're asymptomatic and never develop symptoms, you should get an antibody test, because a symptom is something subjective that you determine. And so you should know whether you had it or not. If, on the other hand, you're pre-symptomatic and develop symptoms, then you have an infection. So that's sort of there. A negative test does not mean you don't have an infection. A negative test means you likely don't have an infection, or the test was false positive, or it was too early in the cycle. That's why this immediate testing is not a good thing. So if you have a negative test and you have symptoms, assume you have the disease, as it is most practical. And I already told you that. So now what about so that's sort of the general rule. So now I want to get to vaccines. And I was trying to think of a pithy, funny title for this. I couldn't. But there's a lot of different kinds of vaccines that are being developed today. It's like vaccines or us, I guess maybe would be it. You can make these things in all sorts of ways. And it's one of the great blessings that our society has compared to societies in the past, that we have such technological capability to do this in so many different ways. And I think a lot of this creates a lot of anxiety and confusion on the part of people. Some of these are new ways, some of these have never been, tried. But the good news is we have so many vaccines that are going to be available to us that in the end, this will be all fine. It's going to be a really bad year, but in the end, we'll emerge from this hopefully better than we were before. So as it stands now, there are basically 4 vaccine types that you should know about. There's the messenger RNA, which I will spend a little bit more time today on, from Moderna, which is Moderna, and the other is from Pfizer. And the Pfizer vaccine is done in conjunction with a company in Germany called BioNTech. There are adenovirus vector vaccines in which a piece of DNA is put into a cold virus that cannot replicate, that makes the protein. And those come from Oxford AstraZeneca, Johnson & Johnson, the Russian vaccine, and the China. So this means China, red. The Sputnik is the Russian, and then these two, the reason they're in blue is those will report their results by the middle of January. So Moderna has results, Pfizer has results, Sputnik 5 has results, and these 2 Chinese vaccines have results. And then finally, there's one that will also come out in January, February, which is a different form in which they just give the protein, an antigen protein encapsulated to the person. So in this case, we're going to give you messenger RNA, your cells make the protein. In this case, we're going to give you DNA that your cells will transmit into RNA that will make protein. And in this case, we'll give you the protein. Inactivated vaccines are like your polio, where you take the virus, kill it, and then give it back. I love these pictures here because that's what the inside of a cell looks like. It is so complicated. It's packed with stuff. And these are actual photomicrographs that were taken of cells. So, you know, we have the genetic code, which is in our RNA, and the RNA unzips, in our DNA, and the DNA unzips, kind of like the zipper on your pants. And when it does, there's a strand left open that enzymes will make an exact copy of. However, rather than making the copy with the same sugar molecule attachment that DNA has, deoxyribose, in this case, it makes it with ribose, a different sugar. That molecule then leaves the nucleus of the cell, comes outside, and it's converted into a protein. That protein is the antigen. So what all these vaccines are doing is focusing on this spike protein that you see here. And they're making that, the cells make that spike protein, which is where the cell is used to attach and get into the cell. So then it's wrapped in a lipid membrane called a liposome, enters the cell, the mRNA is transcribed. mRNA is hugely unstable. So this isn't going to last for very long. We don't have to really worry about it. Theoretically, we don't have to worry about it becoming part of us. mRNA does not become part of us to our current knowledge. And the reason these vaccines have taken so long was to come up with ways to make them stable, which is why you have to keep them at minus 80 degrees. The current vaccine from Pfizer or Moderna is highly efficient or efficacious. And I want to be clear on this, that you're reading a lot of misinformation. The study has shown efficacy. Efficacy means in a clinical trial in which everything was controlled, these are the results you got. Effectiveness is what happens when you mass vaccinate people, when everybody gets the vaccine. So did they give the vaccine right? Was it stored right? Was it out of date? Did it work in all subgroups? All these issues start to play. So I would suspect that this is an efficacy number. These are effective numbers. And so it's probably going to be somewhere around 90%. So that's quite high and consistent with most vaccines. It's been tested in over 30,000 volunteers, half of which got the vaccine, half of which didn't. And Moderna is another 30,000. So there's a fair number of people that have gotten this. Nobody's had any serious side effect. Does require 2 doses. Only 40% of people only 60% of people will follow through with the second dose usually. So a lot of efforts from the government will be in making sure you get 2 doses. You're going to get this card when you get it. The vaccines definitely prevent severe disease. In the case of Moderna, no one who got the vaccine got severe disease. 18 people did in the other group. That's pretty remarkable. They have mild side effects. They've been approved in the case of Moderna, or they've been tested in over 18 in the case of Moderna, over 16 in the case of Pfizer. And studies with both vaccines are now being done in younger age groups. They are in very limited supply. There will only be 50,000 doses of each worldwide by the end of this year. About 1.8 billion for the 2 vaccines to go all over the world next year. And so if you have 7.8 billion people and you have 1.8 billion doses, that means you can only do 900 million people, and you need 75% to get to herd immunity. You ain't getting there. We don't know how it works in function groups. This morning, the data was reported in different groups of Blacks, Hispanics, or Latinos, a whole bunch of groups, and it all looks pretty good. But those are based on 196 people getting an infection. I'd like to see a little bit more to get a better percentage ratio. You know, they said in Blacks it was 100%. Had an efficacy of 100%. Well, if there was one person that got the infection and that one person didn't have the virus, It's 100%, but it's one person. And none of these current vaccines, neither Moderna nor Pfizer, are known whether they stop spread. They stop you from getting sick, but you may still have active virus that you shed. That needs to be determined. Who's going to get them first? Well, you could look at this in two ways. One way you could look at it is get all the young people. They tend to spread, protect the older people in another way, and get all that younger group control. But the way that ended up being done is we're going to treat healthcare workers first, then we're going to treat those who are over 65 living in nursing homes, then anybody over 65 and those with other conditions. And then, so there is a process to this. However, this is the guideline from the federal government, that is from the CDC in combination with an external review board. Each state will make its own decision. So you may get something completely different in California than in Texas, than in Ohio, than in Rhode Island or Florida. It'll be whatever the states decide. Although I do believe that in the end, this is what it will be, because most experts, most health officials aren't going to vary from this.
And so it's not like a first come, first serve. It's not like make sure you get in line. You'll have to actually get approved by your doctor to get it.
Yeah. And if you go if you Google New York Times vaccine checker, you can go to a website and it will actually tell you where you stand in line. So like I'm in the first tranche. I'm over 65 and I'm a healthcare worker. I'm not going to go because I'm not actively practicing. And I feel like I shouldn't take a vaccine away from somebody who is at higher risk than me. But you can figure out where you stand. It'll ask you about comorbid conditions and all of that. So finally, I think one of the big messages I want to deliver today is it's amazing that we're getting a vaccine. It's awesome that we're getting real help. This isn't going to make it go away. People are still going to need to use masks. People are still going to need to social distance. And then you have to make a projection of when this will go away. So we are in a little bit of a situation where there's a lot of people are trying to project a lot of optimism, which is appropriate, and it gets confused with a fair bit of realism, and everything is in flux. When projections made on supply availability by, for example, Pfizer depend on Lonza, depend on airlines, depend on, all of a sudden, Pfizer cuts its projection from 100,000 doses to 50,000 doses. And Moderna cuts its projection from 1 billion next year to 500 million. They're not bad people. It's just the way it works. So this is a graph that tells you how many people need to get vaccinated or how many people need to have immunity for this to end. So if right now it's estimated that 60% of the population will get a vaccine. If 60% of the population gets a vaccine, and that's the only thing that happens, you will not reach herd immunity. A vaccine in order for a vaccine that's 90% efficacious to reach herd immunity will require, this is based on 65%, using 65% as the cutoff, you would have to have 70% of the population get a vaccine. Well, there's some issues with that. We know that 12% of the population in the United States are anti-vaxxers. They're not going to get a vaccine no matter what you tell them. And that's their right. That's up to them. 24% of the population is under 18 years of age, and currently we don't have any approved vaccines, so we've already eliminated 36% of the population. And now we have and then we have 40% of the population that typically in a vaccination program, like for hepatitis or chickenpox, they don't get the second dose. So it seems highly improbable that a vaccine in the near term is going to achieve herd immunity. But what it will do is slow this down. It will give people breathing room. It will start to allow things to be a bit normal as long as we continue to follow some basic rules. So This is probably the pessimistic view, but I also think somewhat of the realistic view. We should be really grateful that we're not dealing with a 50% efficacy vaccine, which was what was originally indicated for the FDA. And I do think we have a chance to get this. And I think that the pharmaceutical companies, health agencies are really going to make a good effort to get people to get vaccinated. The concern about safety is going to go away. I mean, these people have been vaccinated with this already for 6 months, and we haven't heard anything. So I think that's good. So finally, got to deal with Dear Santa. He's apparently coming to my house because my dogs are barking, and that's Christmas. So what do you do?
Oh, did he freeze on us, Dinesh?
I think he did. He's pretty still.
Yeah, we were just getting to the good part.
I know, and that's not like Dr. Amaral to be still. So it has to be Zoom doing something, but maybe he'll notice it and come right back. I hope so.
Yeah. Well, while we're waiting,
I had a lot of questions for him, actually. I know we're almost out of time, but I had a few questions for him.
Yeah, go ahead.
I was just going to say, my concern is I heard that, I heard it's in the news. It's not, I heard from wherever, from the reputable news sources that we all get, that Pfizer's coming up with 20 million doses by the end of the year, which is, already a lot. But that only means 10 million vaccines. We forget exactly what Dr. Amaral just explained to us. It takes 2 doses per person.
Yeah.
And there are over 20 million healthcare workers. So that means that by the end of the year, when people say, well, that takes care of the healthcare workers. No, it doesn't. Only half of the healthcare workers will be able to get a vaccine by the end of the year, according to the CDC, according to all the health officials. And so this is going to take some time. And that's what I wanted him to explain a little bit more to us, because I feel exactly what he said, which is, folks are very, very enthused about a vaccine, as I am.
I'm back.
You're back.
Hey there.
Thank God. You were still, and I knew that something had happened, because you're not a still kind of guy. You keep on going.
Yeah. So I was on the last slide, which is what to do. If we have time.
Sure. Yeah, we do. We do. Angela and I were just chatting.
Keep the conversation going.
Keep the conversation going for our viewers.
And listeners. So that's how. So I don't know where you left. So if you want to gather people, what we did for Thanksgiving is my son stayed home. My daughter's in Rhode Island stayed home. My daughter in Colorado quarantined at home for 14 days. That's a luxury she has because she works from home. Quarantined for 14 days, got in her car, drove from Colorado to Florida. When she got here, she wore a mask for 7 days. She is now part of our house. She's here. She'll be here till Christmas. We'll be celebrating with her. Now you can do that with 7 days in a test. And I'm going to tell folks, I have a friend that just did this, and he did it at 5 days, and then at 6 days got a test. They were both negative, and he was positive, and he gave it to everybody in the house.
Oh my God.
If you're going to do 7 days, it means 7 days. And then a test on the 8th day. If you're going to be if you're in California, you can be outside. If you're in Florida, you can be outside. If you're in Rhode Island, Michigan, Wisconsin, you can't be outside. If anybody's going to come in your house, just wear masks. It's like Santa needs to wear a mask. He's not coming to my house unless he has a mask, because it's spreading in the house. And the way to do this, the only way to do it, if you're going to have people, it's got to be fast. Like, come in, say hello, give a present, because remember, it's 15, 30 minutes and they're in your house. Put some fans in your house, open windows, run ventilation. Try to make your indoors an outdoor environment. The best thing is celebrate. And the best thing is to just celebrate with the people who are in your house. Celebrate through Zoom. And whatever you do, don't hug anybody, because that is pretty close contact. So I don't have great news, but And I'm sure nobody's going to follow that, but you can do it. And, it's Denise was talking earlier. I mean, you create a bubble, so that bubble should be fine, or your social bubble. It should be those in your home, but your social bubble would be fine as well. So, dear Santa, I don't want you coming to my house if you don't have a mask on. That's the bottom line. So there is a light at the end of the tunnel, and I think it's probably closer than today. I'm thinking it's closer than what I thought it was yesterday, but it's going to probably be summer, fall of this year. Doesn't mean we're going to be normal. It just means things will be feeling pretty good. It's a simple rule. The less you do, the safer you are. And the paradox for me, and what hurts me the most, is to think that when all of us don't do everything we can and argue that, well, people need to go to work and people need to feed their families. I agree. But when we're not doing that, they're the ones that are at the greatest risk also, and those least able to afford the consequences. So, following the rules is about all of us and helping everybody. So the less to do, and then wear a mask, physically distance, and to the extent possible, enjoy the outdoors. Just because it's winter doesn't mean you can't go for a walk. And please get vaccinated. I will put up a post about which ones I think as data comes available. So far, I have no concern, but I'm not making any recommendations. And now I'm happy to take any questions.
I know, Denise, you had some questions that we were talking about.
Well, my question is more of a common question, though, and I think and you gave that point out tonight, but I think it'd be worth it if you could reemphasize that to folks, because there's a lot of last thing we want to do, of course, Dr. Amaral, as you pointed out eloquently, which is give false hope. I mean, you want to be optimistic, but at the same time, with a dose of realism. A famous Portuguese writer passed away a few years ago. The only one that got a Nobel, José Saramago, he used to say that, people used to call him a pessimist, and he said, no, I'm just an optimist with a dose of reality. And so I think that, sometimes we want to look at, we say we're pessimistic, but we do have to have that dose of reality. And so my question was for example, there's been a lot of talk about the 20 million the 20 million doses that Pfizer has announced that they'll have, here pretty soon, within a few days. But I was just reading something in one of the journals, one of the health journals, and it was saying that we forget that that's not for 20 million people. That's for 10 million people, because everybody's going to be getting, the vaccination twice. So according to this article that I was reading from one of the health journals, it said, that there's over 20 million people, which I didn't even know, 20 million people who work in the front lines of healthcare in the United States, huge country of 330 million people. So you're talking about only half that are going to be vaccinated within the next few days. So it's even going to take a while for the healthcare professionals who are, to be vaccinated. So my thought is we need to kind of, as you pointed out, people are thinking that once the vaccine comes forth and they're in one of these groups, that, it will all be over by May and we can just go back to the reality pre-March of 2020. But you're saying that there will be a sense of new normality, but it will be a new normality. It won't be, even if in best case scenario, if the majority of the population or a good percentage of the population is vaccinated and things are going much better than they are, of course, today, by June or July, let's say midsummer, it still isn't the normality that we had in the summer of 2018 and 19.
Yeah. And so those are all really important points. And I just want to make a plug for the Casa de Vicus in Lisbon, where the José Saramago Museum is. I love that building.
Yeah.
So, one of the ironies of this is if you take the people in the two highest risk groups, extended highest risk. So if you take people who are healthcare workers, live in nursing homes and prisons or long-term care facilities, people who are over 65, people who have chronic comorbid conditions, that's 180 million Americans. and I might be underestimating that. I wrote something about that this week. So, and I can't remember if it's just the first group or all of those four. Group 1A, 1B, and part of group 2, it's over 180 million. As you point out, Pfizer's saying we're going to have 20 doses. That's enough for 10,000 people. That's not, that's, a drop in the bucket. Now, as I think I wrote this week, it's like the ripple of a stone in the ocean at Nazareth, where the waves are really big. Now, but all these things help, if rather than having, 4,000 people, 200,000 people, and instead of having 1 million people get COVID a week, if you get 10 million people vaccinated, that's 10 weeks of infections. So we have to really kind of think of it that way. And so, as you said, the pessimism, it's not pessimism, it's optimism with a dose of reality, because we can't become over exuberant. We can't not follow the rules. Here's the other thing. If you got a vaccine and it only works in, let's say, right now it's 95%, but I'm pretty confident it'll be a little bit less, let's say 90. That means you have a 10% chance that you're not covered. Now, herd immunity doesn't mean the virus went away. What herd immunity means is you won't get epidemics, so that in, I don't know, whatever city you're in, there won't be 10,000 people that got it this week. You stop epidemics. You don't stop the disease nor its spread. That's why you're going to need to wear a mask. There'll be, some degree of, you're going to need to socially distance. So it's easy to think, and I fault a lot of the narrative that goes on in the world that has made it seem like a vaccine is the end all and be all magic bullet of this. It's not. And as you pointed out, so imagine, I'll do some quick numbers. Please don't hold me to the exact number, because I'm old and my memory fades. I'm going to use Pfizer. The United States has committed 100 million doses from Pfizer. It has an option to purchase another 200 million. Europe has already committed 200 million. Japan has committed, I think, about 200 million too. UK has committed 20 million or so. Israel has committed purchase of 6 million. And those are the countries that I know. Canada has committed to purchase. Okay. They're only going to have.
Froze again.
I think it's.
I think it's his internet that's there or something.
Yeah, I believe it's.
They have contractual arrangements with all these companies. So this 1.4 billion is going to get spread out around the world.
So, so I think essentially, if it seems like
they're probably only going to be able to get to 500. So,
there must be a lot of Zooms happening right now.
That is that's the
dilemma. Better results here, I think, will be good, because then we'll get an additional, couple of billion doses.
So, Dr. Amaral, you were freezing. You were freezing a bit here and there, but I think we got the. It's all right. We got the gist of the message.
Did you get the gist?
I think so.
The gist is that. The gist is that Denise is right. It's not the end, but it's great. We're moving in the right direction.
And
I had only one other question that I've read about is the issue with masks. How, of course, masks are the thing, and as a matter of fact, there's been in the news that President-elect, when he gets into office, will, by recommendation of Dr. Fauci and other medical professionals, including the new appointed director for the CDC from Massachusetts area, actually, Massachusetts General, from your neck of the woods area, and so they're all recommending like a mask mandate, for 100 days, that kind of thing. But I've read where there's we should actually be wearing the 95 masks and not the cloth mask. What are your thoughts on the mask? Any mask will do,
so
or should we actually move to those 95 masks?
Okay, so there's a whole bunch of elements in that question that I want to be clear. So President Biden has not asked, President-elect Biden, has not said he will institute a 100-day mandatory mask law.
Correct, yeah.
What he has said is that he's going to ask all Americans to wear a mask voluntarily for 100 days.
Right.
People, we're like kids. When you get told to do something, you don't want to do it.
Uh-huh.
Part of the problem is when you give people a mandate, so it makes a lot of sense to say it's a voluntary. So, and, I think it's a great idea. In fact, they showed in Germany that they instituted a compulsory mask law in Germany during this last thing, and their cases dropped by 50% in like 2 weeks. People want a randomized control trial for masks. You can't do it. You can't do that study. It's not possible because you can't give somebody a mask and then, when did they wear it? Where were they? Did they go to the restaurant? How much time was it? It's just not conceivable. The only way you can do it is by doing big data analysis. And that's the way in the future, most of our science is going to be done. It's not going to be done in small clinical trials. It's going to be done by analyzing 500,000 people. And what they all show is using a mask reduces your incidence of capturing the disease by somewhere around 50 to 70%. So we should really stop arguing about that. Now, the next question is an N95 mask better than a cloth mask? The answer to that question is yes. The filtering capacity of an N95 mask is better than it is of a cloth mask. And there's a lot of stuff that's been written about bandanas and all that. But let's start at the beginning. Anything is better than nothing. So you're getting incrementally better protection up to the N95 mask. During the SARS epidemic in China, there was a study done of healthcare workers. And it's interesting that in that study, whether they wore an N95 mask or a regular mask or paper mask or whatever, they all had a much lower incidence of disease. So it would be better if you wore an N95 mask. The problem is there aren't enough. As it is today, PPE is in limited supply. You can, for example, I was in Lowe's recently, and there were N95 masks in there. What my wife does is she wears 2 masks. But essentially, all you're doing is creating a barrier, and you're just getting more filtering. So you could wear 2 masks. I have a luxury, which is I do a lot of woodworking. And so I had a supply of N95 masks in my workshop when I'm sanding and cutting wood, because it's like, stuff. And so I still have 1 or 2 left, and, I use them, but any mask is better than no mask. And yeah, N95s would be better, but we need to make sure that those who, you asked me a question, Denise, on one of the webinars, which I ended up writing a post about, and it was about how do healthcare workers feel? And, there's a lot of people that are, we can call them heroes, but, basically they're doing their job, and we as a society owe them we owe them the obligation to do all that we can to keep them safe so they can take care of us. It's really that simple. And
Great.
So if there was a plentiful supply, then I would say wear an N95 mask. But right now, the thing is this, the healthcare worker can't do anything about what they're doing, right? They're going to face these patients. We can minimize our exposure. Am I breaking up again?
Nope, you're good so far.
We can minimize our exposures and lower our risk by our exposures at the same time as wearing perhaps what might be less effective mask. So that's a good question.
So one last question, Dr. Amaral, before we wrap it up.
Yeah.
You did mention that 12% of the population are anti-vaxxers right out of the gate, but then there are still people that maybe aren't anti-vaxxers, but have, concerns about the side effects of the vaccine. And I know that you had listed there were mild side effects. Can you talk a little bit about what those were? And then,
Sure.
What are some of the other concerns that people have, and should they be concerned? I know, a lot of the whether it's true or not, or that, there's other chemicals in a vaccine like formaldehyde or tar or some of these other things that, why would you put those kinds of things in your body? So can you just talk a little bit about the actual ingredients of the vaccine that you're aware of and what some of those side effects were?
Yeah. So, I'm going to start at the highest level on this.
Okay. We could do a whole other webinar on that if it's needed.
Yeah. So, I think it's a great question, also an important one, because there's just a lot of misinformation floating around. People have said they come from stem cells and that there's this and that there's none of that's true. Basically, when you make a vaccine requires two parts. It requires something that the body will develop the antibodies to, that is the antigen. The process of getting an immunologic reaction is a two-step process. There's a cell that has to recognize it and present it to another cell that makes the vaccine, that makes the antibody, and those are called presenting cells. So when you make a vaccine, in order to accelerate that process, you need to have what are called adjuvants. There are things that get those presenting cells excited to take the right thing to the other molecule. So all vaccines have an adjuvant of some sort. It can be glycol. There's different molecules that have been used. And those molecules are important, and a lot has been learned over the years on those vaccines as to picking those that are safe. I cannot tell you specifically in every vaccine right now what the adjuvants are that are being used. So that's number one. Number two is the vaccines, the mRNA vaccines are the vaccines from Moderna and Pfizer BioNTech, and those are coated in a lipid, so a fatty shell. Now, we have to be realistic about this. You're only getting a really small amount of this. It's not like we're injecting you with, a lot, and it's not repetitive. I'm presuming at the moment that the metabolism of those are just like the metabolism of any fatty material, and that they actually, fats are kind of neutral in the whole process. As far as the Oxford AstraZeneca vaccine and the J&J vaccine, those have an adjuvant, and then they have a virus, and the virus cannot replicate. It's an adenovirus. They've been well studied they're used in many different vaccines, including Ebola. I suspect that if you thought that Ebola was in your neighborhood, you wouldn't worry too much about getting an Ebola vaccine. I always laugh and think, if there was a vaccine for rabies and they said to you, hey, Angela, somebody got rabies in 3 streets down, everybody would go get a rabies vaccine. So there's a risk to everything we do. Now, what are the side effects? So if you get vaccinated, you get an immune response. The reaction you get, what you're experiencing right now, Angela, a lot of it is simply an immune response. Muscle pain, aches, bony pain. Why does your bone hurt? Because you stimulated your marrow to make all the T cells, and you're making a lot of B cells. There's cells that you're making to go fight this infection. So you get bone pain, you get aches, you get fatigue. Why do you get fatigue? Well, your energy is being taken from your normal activities to your response, right? So you get fatigue, and you can get a low-grade fever. Those are all part of any kind of a immunologic response. So ironically, we call them side effects because you were sick. You weren't sick. You got the vaccine, and then you got those effects. But if you had the disease, we would call them symptoms. So the difference here is that those are the kinds of things that are being reported. In fact, people with the Pfizer vaccine have, some might call them even moderate. I mean, they feel pretty lousy, but it lasts a day or two, goes away, and then you're protected. So I will certainly I will look for more. My problem right now is that pretty much, other than in the early releases of the phase 1-2 trials, there is no data available. All I can get access to, like many, are press releases.
Right.
And the FDA has said they're going to be transparent, which is really good. But so far, the transparency is to tell me it's effective in, 95% of people over 65. That's not transparent. I don't know. Didn't tell me how many people, didn't tell me a lot of important information. On the other hand, I do think that the FDA actually is taking this very seriously. I think so we can, there's nothing 100%, but we should have confidence that they're making the right decision. And it'll be interesting to look at the data. So maybe next time I can talk a little bit more about that. But these are all lengthy response questions because there's a lot of elements to
Sure. Well, and we have one more question from Facebook that we'll throw out there and then we'll wrap it up. Is there a chance that the virus could mutate and then therefore the vaccine would be ineffective?
Yeah. So it's another excellent question that comes up a lot. And the answer to that, here's the simple answer: yes. However, you want some more information. So the answer to that question is yes. But one of the good things and so again, a lot of speculation, a lot of stuff that people say, most of it not substantiated with facts. So you all know that there's what's called, you don't know what it's called, probably. It's called DG164, which is a mutational variation of the virus. So for the audience, I want you to all get this piece. So you understand efficacy and effectiveness so that when you go to your cocktail party by Zoom, you can look good. And this is the other one. A virus strain, because you keep seeing, there's a new strain of the virus. Okay, here's how you define a strain. The strain is defined by one of four characteristics. It's a mutational change in the virus that results in one of four things. It's more infective, it's more lethal or more severe. It will not respond to an antibody, has a different immune antigenicity, or it won't respond to therapy. To date, there is no documented proof that any of those things have happened. RNA viruses do not have a way to correct mistakes. So we have those, we make mutations, but we have mechanisms that correct it. RNA viruses don't have it. It is standard for RNA viruses to undergo mutations. We shouldn't get upset. That's just the way they are. In fact, interestingly, the COVID virus mutates at a rate, SARS-CoV-2 mutates at a lower rate than influenza. Influenza has resulted in this 60%, because when it's mutating, it's actually completely changing itself. And that's because it has multiple antigenic components. So people are working on a universal vaccine for that. In this case, any changes that have occurred have not changed the ability to respond to therapy. There's no documented knowledge of antigenicity. And then this issue of infection and infectivity and lethality, there's culture experiments that suggest it might be more infective, but there was a big study done recently that suggested those haven't changed either. So we never know the future of what this virus will do, but here I want to leave you with the most positive information I could give you on this. A virus, in order for a virus to remain functional, it needs to be able to continue to replicate. If it becomes more infective and more lethal, it will wipe itself out. This is math. It's not, the virus doesn't think. So what ends up happening is over the course of mutations of viruses, the virus will have a tendency in an evolutionary process to become more like its standard form. In this case, it's a simple cold virus. So I would predict that over time, the virus will become less severe, and perhaps maybe as infective or more infective. It's called regression to the mean. So today we have 4 circulating coronaviruses that give us the cold. We never knew about them until this year. And that's where the mutations are most likely to head. That doesn't mean that in the middle of a cycle, you won't end up with a really bad virus. So that's what happened probably in the 1918 influenza. The original virus wasn't that bad. It mutated to a really bad virus in the end of the year. And then the following year, it mutated to a really mild virus again. And that's where it sort of has remained for the most part. So we always need to be worried about that, but can't worry about everything. So I'm not worried about that. I'm thinking it's going to get better, not worse.
Well, that's good to hear. And I actually appreciate you pointing out the difference in mutation rates between the coronavirus, the COVID-19, and the average flu, because I think people are still making that correlation that it's like the flu, and the flu vaccine isn't as effective, and so we're gonna have the same problem.
One thing, and the other, just one last point on that is, I really think we should probably completely stop making analogies to the flu in general. And it's not that people haven't been led to make that assumption, because that's the way we talk about it. It's a respiratory virus. But now we know this is much different than influenza. Influenza is a respiratory virus. This virus has a main respiratory component, but it affects other cells. It's operating through different kinds of receptors. You see people with renal failure, you see people with vascular disease, you see people with clotting. Those are not hallmarks of influenza.
Right.
And so it's a different disease. It's frightening to think that people are projecting that by the middle of, by maybe around March or April next year, that as many people may have died from this disease as died from influenza in 1918.
Wow.
Think about that, because 600,000 people. Think about that. In 1918, there were no ICUs, there were no antibiotics, there were no antivirals, there were no ventilators. There was a shortage of nurses and doctors fighting in the war. Doctors were poorly trained. That's frightening. So I think we're deminimizing the illness by comparing it there, and people should stop worrying about that part on the vaccine. It's completely different.
Agreed. And on that note, I think we're going to wrap it up, but this has been extremely informative as always. Thank you so much.
Thanks. It's a privilege for me to do this.
And I know that we'll line up another one in another few weeks, maybe after the holidays. We'll see how things are going. Yeah. See where the vaccine is and but really appreciate your time.
Boas festas para toda a gente. And remember, Santa's got to wear a mask. Okay.
That's right. I love that one. Thank you. Thank you. Stay safe.
Boas festas.
Boas festas.
Thanks, everybody. All righty.
Thank you.
Bye-bye.